If I had to compress the cholesterol diet evidence into one sentence, it would be this. Food can move LDL, but usually by nudging the body's cholesterol traffic, not by performing a medication-sized rescue. LDL matters because trials and meta-analyses consistently link larger LDL reductions with fewer vascular events, especially when the reduction is sustained. So the food question is not, which single miracle food cleans arteries? It is, which repeatable eating pattern changes LDL enough to matter for my baseline risk?
That sounds much less dramatic than the videos people see. Some thumbnails basically promise lower cholesterol naturally, no pills, or say a portfolio diet can rival a statin. What should a viewer do with claims like that? Are we talking about a few points on a lab test, or something clinically meaningful?
The cleanest food mechanism is viscous soluble fiber. In the intestine, certain fibers form a gel that interferes with bile acid recycling. Bile acids are made from cholesterol, secreted to digest fat, and usually reabsorbed. If more bile acids leave in stool, the liver has to pull more cholesterol from circulation to make replacements. That can upregulate LDL clearance. It is not detox. It is a small shift in the liver's accounting system. A recent oat-based crossover trial is a useful reality check. Adults with mild metabolic deterioration ate fermented and non-fermented oat products enriched with fiber and protein. During the fermented oat period, LDL fell by about 0.12 mmol/L, which is roughly 5 mg/ml. Non-HDL also fell modestly. The authors did not find that fermentation itself clearly beat the porridge version. The likely active ingredient was more oat fiber, especially beta-glucan, not a special probiotic spell.
So if oats alone are not a giant lever, is the real move stacking several small levers? For example, more soluble fiber, swapping saturated fats for unsaturated fats, maybe sterile fortified foods, and fewer refined high glycemic carbs. Or does that become diet math that looks better on paper than in real life?
Exactly. I would rank the practical hierarchy like this. First, replace saturated fat-heavy foods with unsaturated fat foods rather than just adding healthy items on top. Second, add viscous fiber from oats, barley, legumes, psyllium-style fibers, and similar foods if tolerated. Third, use lower glycemic, less refined carbohydrate patterns when glucose regulation is part of the problem. Fourth, consider sterile fortified products only as a verified product choice, not as a vague plant food halo.
Can you walk through what is actually entering the body? People hear eat cholesterol, get cholesterol, but then they hear dietary cholesterol is not the main issue. Where do fiber, fat type, and sterols act along the route from mouth to LDL particle?
Here is the responsible version. Some cholesterol is absorbed from food, but the liver also makes cholesterol and packages it into lipoproteins. Saturated fat tends to raise LDL more reliably than dietary cholesterol for many people, although individual response varies. Soluble fiber works in the gut lumen. Sterols, when present in fortified products at meaningful amounts, compete with cholesterol absorption. But if someone has very high LDL, chest pain, diabetes, kidney disease, or known cardiovascular disease, diet changes should be coordinated with a clinician, not used as a delay tactic. Low glycemic eating is a good example of context. A 2026 systematic review of 25 randomized trials found low GI diets lowered LDL by about 0.15 mmol/L, around 6 mg/dl, while also improving fasting glucose and HbA1c. The effects were stronger in people with type 2 diabetes, higher fasting glucose, and interventions lasting at least 12 weeks. So this is not mainly a cholesterol hack. It is a metabolic pattern change that can modestly help LDL while doing more for glucose control.
Who is the best fit person for this approach? Suppose someone has mildly elevated LDL, eats very little fiber, uses butter and cheese as default fats, and has borderline glucose. Is that the person where food changes are most likely to show up on the next lab?
Yes, diet has the most visible LDL room when the current diet is pushing LDL upward. If someone replaces butter, cream, high-fat processed meats, and low-fiber refined starches with unsaturated fats, legumes, oats, nuts, intact grains and vegetables, the lab may move. If they already eat that way, the same oat bowl may barely register. The useful expectation is often a modest percentage change, not a guarantee. And the higher the person's absolute cardiovascular risk, the more important it is not to confuse helpful with sufficient. Product quality is where people can accidentally fool themselves. A cereal may say, made with oats, but contain little viscous fiber and a lot of added sugar. A spread may contain plant sterols, but the relevant question is the amount per serving and whether it replaces saturated fat rather than adds calories. For supplements like psyllium, start low, increase with water, and separate from medications when advised, because fiber can affect absorption or tolerability.
How would you tell if it is working without turning every breakfast into a science project? If LDL drops 5 or 10 milligrams per deciliter, is that success, noise, or a sign to keep building the pattern?
I would usually give a real dietary pattern about 8 to 12 weeks before judging the lipid response, unless a clinician has set a shorter timeline. But there are boundaries. Very high LDL, suspected familial hypercholesterolemia, prior heart attack or stroke, pregnancy, complex kidney or liver disease, or lipid changes from medications deserve medical guidance. Also, do not stop a statin or other lipid medication because oatmeal entered the chat. Food can be part of treatment. It is not automatically a replacement. So the latter is not glamorous, but it is useful. Start by removing the LDL-raising exposures you actually have: excess saturated fat, low fiber, refined starch patterns, and unverified health halo products. Add viscous fiber foods you can eat consistently. Use unsaturated fats as replacements. Consider low GI structure if glucose markers are part of your story. Then retest, compare the absolute LDL change, and decide with your clinician whether the result is enough for your risk level. That is how food earns its place without pretending to be magic.